Good evening to all of you, and thank you for making the time to join this webinar. My name is Dr. Moro Salifu. I'm the Chair of Medicine and also the Director of the NYACP Task Force that is sponsoring this webinar. I'd like to thank all the task force members for making it possible to come to this topic. We had several meetings, and then this topic was very, very important to all of us. Because many of the equations and algorithms in medicine have the race component of the equation, and whether that impacts health disparities and health equity or not had always been a point of discussion across the country. But in the last couple of years following COVID, many of these discussions have boiled down to actionable items, and today we're going to be hearing more about that. I'd like to also thank the organizers from the NYACP administration, Isaiah Wright, for always being there and making sure that we organize these programs, and also to the executive leadership at the NYACP. And then thanks to all the medical students, residents, and also members of the NYACP that are present today. I want to announce that we have 12,000 members of NYACP members. It's very strong, and we're hoping that these kinds of programs from the task force, the Health Equity Task Force, will get to all of you. So we can go to the next slide. So a couple of announcements. March 19th, we have the Elder Abuse Series Part 2. March 22nd, we have the Women in Medicine Series Part 1, and May 16th, we have the Women in Medicine Series Part 2. On July 18th, we have the Women in Medicine Series Part 3. You are going to receive emails regarding these. You could also scan these barcodes for more information. There is the NYACP annual meeting for 2024. It's going to happen in Tarrytown, New York on Saturday, October 26, 2024. Abstracts are now being accepted. The QR codes are below. You can scan them and you can submit abstracts, and hopefully you can join us in Tarrytown. Beautiful, water scenes, and we can have a nice day together. So now to the reason why we are here this evening. Again, the reason was to bring programming from the task force to our membership in very, very important areas of health disparities, health equity. Today we are very fortunate to have Toni Eyssallenne. She's a physician leader, by all rights. She's published extensively. I've seen some publications in the New England Journal of Medicine, which I was very, very impressed about. She's double-boarded internal medicine and pediatrics, deputy chief medical officer in the chief medical officer's office at the NYC Department of Health and Mental Hygiene in New York City. She was also former New York market medical director for a company called City Block Health. It's from there she transitioned to the chief medical officer's office. She's also faculty for both internal medicine and pediatrics at University of Miami currently. And I was just told, she actually told me just a few minutes ago that she actually practices at Flushing's Hospital, seeing patients, which is very, very remarkable and very impressive. So thanks for joining us. For additional educational opportunities, please visit ACP's online learning center. You'll get a lot of information on a lot of programming coming from the NYACP. So without further ado, Dr. Eyssallenne, the floor is yours, and looking forward to your, discussing this very important topic to our membership.
Thank you so much. It's great to be here. Thank you for the generous introduction. I'm going to try to see if I can share my slides here, and we can go ahead and get started. Really appreciate the invitation, Dr. Salifu, and really great communications with Mr. Wright here. And we're just really going to dig into some topics and let you know what we're doing here at the New York City Department of Health and Mental Hygiene to address clinical algorithms that have race adjustments and ending that racism. So let me just share my slides and give me a second here. Oh, okay, very good. Can everybody see everything? Very good.
Yes, we can see it.
All right, awesome. And do you see your little, you see the little faces? Do you see your faces too? Yes, but
Yeah.
is it blocking anything, or you're good?
No, no, it's not blocking.
No? Okay. I might move it around if that's distracting. I'm sorry, but I'm going to move it around in case there's parts of the slide that I would like you to see. So we're going to dig in. We're all here today to learn about the New York City Coalition to End Racism in Clinical Algorithms. And before we start, it's really important that we ground ourselves in understanding the difference between race and racism. So race is a socially and politically defined construct that categorizes human beings based on observable physical features and ancestral origin. But when we're talking about the system, we're talking about racism, right? Racism, the system, operates at multiple levels. We're talking about internalized racism. We're talking about interpersonal racism. We're talking about institutional and structural. And all of these manifestations of racism can influence one's health. And it's important that we are all grounded and understand that it is racism, the system, and not race, the social construct, that drives racial inequities, particularly when it comes to health. And we're talking about disease burden, access to care, and clinical algorithms, not only in New York City, but in the United States as a whole. So in the fall of 2021, the New York City Board of Health declared racism a public health crisis. And in response to that, the New York City Department of Health and Mental Hygiene convened this coalition, which we affectionately call CIRCA, which is a coalition to end racism in clinical algorithms in order to improve medical treatment and care for people of color by eliminating algorithmic race adjustments in clinical care. So why are we talking about this? Why is this a thing? Well, in medicine, we are taught with the lens of race essentialism, particularly in medical education. And what is race essentialism? It's basically a misinterpretation of what race does and does not represent. And it is an essential belief that there are biological differences between racial groups, right? So there's a biological difference in the physiology of a white person versus a Black person, for example. And that has permeated our medical education since its inception. This has spilled into the misuse of race in clinical algorithms and clinical guidelines. And there are numerous examples of diagnostic algorithms and practice guidelines that adjust their outputs based on a patient's race. And this is despite the fact that we have data from the Human Genome Project, for example, that demonstrates that there is more variation within a race than between a race, right? All right, so some people maybe on the call or folks that you have conversations with will say, wait, what about genetics and race, right? Like, what are you talking about? So I have a slide for those human beings. While population descriptors have been used for genetic studies, they have not named individuals consistently or in a principled manner. And they often reflexively use race and ethnicity without ever really truly thinking about it very thoughtfully. And so if we use African descent or European ancestry as an example, these are these sweeping associations that they use with disease alleles, right? And they are problematic and often very inaccurate. So the biggest example I can give is that of sickle cell disease risk. So Black race or African ancestry is very often conflated or associated with sickle cell disease risk. And sickle cell disease is associated with a genetic mutation that confers resistance to malaria and is concentrated in specific areas across the African continent. Not the entire African continent, specific areas across the continent. It is also found in the Middle East. It is also found in the Mediterranean, Southeast Asia, and Latin America. And so using race as a proxy for genetics is not only problematic, but it can be incredibly harmful. And so what are the goals of CIRCA, our Coalition to End Racism in Clinical Algorithms, now that we understand where all of this is coming from? Well, we want to raise awareness amongst health system partners on how race correction can contribute to racial health inequities. We want to eliminate race correction, and we are focusing on each member of the coalition needs to focus on one clinical algorithm that they want to de-implement race. And they pledge this, and they pledge to stay with us over a 2-year time frame. We want to measure what the impacts are. We want to elevate and communicate the commitments of coalition members. And we also want to not only avoid the potential impact that race correction may have, but also understand and move forward and engage with the harms that have been done with patients who have been subjected to these clinical algorithms with race adjustments and have contributed to poor outcomes. So what did we focus on? We focused on vaginal birth after C-section, estimated glomerular filtration rate, and pulmonary function tests. So vaginal birth after C-section and estimated glomerular filtration rate were the easy ones to focus on, because particularly EGFR, the work that had been done to de-implement race adjustment in the equation that diagnoses kidney disease had been done for like 10 years before the coalition had started. There had been advocacy around this. The National Kidney Foundation actually made a statement against using race adjustment. We had a lot of support from the professional organizations. The same came with vaginal birth after C-section, where the Professional Society for Obstetrics came out and said that don't use race adjustment in the calculation that is used to decide what the risk factors are, or what the risk is for giving a woman or a birthing person the opportunity to have a vaginal birth after they've had a C-section. This actually disproportionately affected Black and Latin human beings. And so pulmonary function test, on the other hand, did not have any support from the American Thoracic Society. And so because of COVID and because of all of the importance of understanding lung function and the underdiagnosis of lung disease, particularly in Black and Asian people, we thought that this would be a great algorithm to tackle and see if we can get some support from the professional societies to go ahead and move toward that. And it was really important to do that also because, as you could see from the COVID pandemic, who was affected the most in those populations. All right, so what's the how behind CIRCA? How do we get this coalition off the ground? So basically, it's a citywide effort. There are multiple members, and the members are health systems, right? So we have safety net systems, like downstate, for example. We have One Brooklyn Health, for example. We have H&H, for example, and we focus on these. And we have some private systems like Mount Sinai, for example, who decide that they're going to commit to one of those 3 priority algorithms, right? One of those 3 that I just showed you, and their commitment is to de-implement race adjustment in their algorithm at their institution. We in the health department serve as a convener, so we get them all together. We have meetings every 2 months, and basically what we do, the format is basically we have either a presentation, like a grand rounds presentation on a specialty topic, and then we go into breakout groups in the second half of the meeting. We launched in 2021, and the coalition was slated to run for 2 years before we took a pause, evaluated where we were, and see how we were going to go forward. And so we've just finished the 2 years at the end of December, and we're going forward with the next iteration of CIRCA for the next 2 years. We had an inaugural report that was published in 2022, so a year after the coalition launched. There it is, just in case you can't see it. And we held all of these meetings virtually, but we've had some in-person meetings to celebrate the 2 years. We had a celebration in December, and we're about to have the new launch for the new coalition timeframe that's going to start in May. So what did we ask of the coalition? We asked them to achieve 3 particular deliverables. One is to end modification of race modification in at least one of the 3 priority algorithms that I shared. We wanted to ask them to evaluate the impact of using these algorithms without race on the inequities and on patient outcomes. And then we wanted to create and implement initiatives for patients, particularly engaging them around the fact that their care may have been impacted and they may have been harmed by these race modifications. So like I said, we just ended the last year. The first year of the coalition focused on the work plans, developing the work plans and the evaluation plans. And then the second year of the coalition was dedicated to the patient engagement plans and the implementation of the work and the evaluation plans. All right, so what are we doing next? Like I said, we are excited to launch the next phase of Circa, which is going to be on May 10th in 2024 in person at the New York City Health Department. So we're excited about that. We are going to continue the work for spirometry. Like I said, we did not have for spirometry, the professional society, the American Thoracic Society. We didn't have their backing when we first started this in 2021. And after a lot of advocacy and a lot of meetings and a lot of advocacy that was done prior to the coalition, for sure, they finally, in March of 2023, actually made a statement to de-implement race in spirometry. So that was a big deal because that had held up a lot of the work that we were trying to do around spirometry in the coalition. Everybody was like, well, ATS hasn't made a statement, ATS hasn't made a statement. And so finally we had a statement from ATS in March of 2023. And so the point of the next phase of the coalition is to just take their work forward, help the systems that have dedicated themselves to the spirometry algorithm to de-implement racism, de-implement the race adjustment in their spirometry. It's a little bit harder with this one because there are machines that are programmed. We have to think about the hardware. We have to think about the software. Some machines need to be replaced. There's a cost to that. And so we're helping accompany these health systems in making those decisions. For the EGFR group, of course, all of the systems that were involved with the coalition have de-implemented the race adjustment. And now that we've done that, there's a consequence. And the consequence is that now you have a lot of patients who didn't have kidney disease, who now have kidney disease, or folks that had kidney disease that have more significant kidney disease and are now on the transplant list. And so now what do you do with all of this? What do you do with the increase in nephrology referrals? What do you do with folks that are now on the list that weren't on the list and that increase in the list? And so we're focusing the efforts of the coalition on equity to access transplant. And so that's how the EGFR committee has transitioned. And then finally, for the VBAC group, they have all, VBAC was different because the feedback was that not everybody in the health systems were actually using the VBAC calculator to decide, but people were just kind of with bias making decisions on whether or not folks should get a vaginal birth after C-section. And so now what we're doing is we're going to focus on the patient engagement piece. And the patient engagement piece is going to include like an instructional video. So folks have an idea of their choices for their birth plan. Not just because you've had a C-section, do you automatically get a C-section, particularly if you're Black or Latin, but you are able to get education about a trial of labor, even if you've had a C-section, if that's what your choice is. And so making sure that we're leveling the playing field there. And then finally, we are starting a new subcommittee on race-based prescribing in hypertension. So let's talk a little bit about that. So race-based prescribing for Black patients has been happening because of practice guidelines from the JNC8, as well as the ACC, the American Cardiology Committee, that recommended that Black patients with hypertension without comorbidities get the initial treatment with a thiazide diuretic or a calcium channel blocker as opposed to an ACE inhibitor. And while providers have been following these guidelines, there is no improvement in hypertension in Black patients, right? And so not only have we shown that there hasn't been improvement, but these guidelines could be limiting treatment options for Black patients, particularly when it comes to treatment of chronic kidney disease. All right, so how did we get here? What is JNC8 wrong? Like, what happened here? Well, let me give you a little bit of background. So JNC8 was particularly influenced by the results of a 2002 randomized controlled trial called ALL-HAT. And in the study, what they did was they looked at folks that had first diagnosis of hypertension and first line of treatment of either a thiazide diuretic, an ACE inhibitor, or a calcium channel blocker, and to look at the outcomes for that. what they found was that there was a 15% relative increase in stroke in the lisinopril group versus chlorothalidone group. And so they were like, what's going on? Why is this happening? So they race stratified the data, and they found that there was a 40% relative increase in stroke in Black patients versus non-Black patients, and that the systolic blood pressures were about 4 millimeters of mercury higher than in Black than in non-Black patients. So listen how they actually defended this or justified this difference. There was a study that was done in Sweden that was similar, a randomized controlled trial in Sweden where they looked at lisinopril and chlorothalidone or thiazide diuretic, and there was no difference in their outcomes. And so based on that study, they concluded that race must be considered in the context of the heterogeneity of race. That's literally their justification, that one study. And what they say is that, well, because Sweden is a homogeneous population and the US is a heterogeneous population, it has to be race. So don't give Black people ACE inhibitors. That's literally the paper. I read it, like I read the paper and I was like, this is okay. That's all right. I didn't know what to say. Now that we understand this, now there might be people who are like, I don't care, randomized controlled trials are the golden, rule. This is the standard, data. Randomized controlled trials are like, that's the way to go, right? That's the North Star. And so never mind you, Dr. Toni, you don't know what you're talking about. Okay, no problem. People started to look at this. And in particular, this study came out in 2022. Let me try to move this out of the way so you can see it. It was in 2022. And basically the study looked at hypertension control and prescribing differences in Black versus non-Black patients with hypertension without comorbidities. This was a retrospective observational cohort. They used 2 years of data, and they looked at the medical record. And they look at patients that were adult patients. And what did they find? They found that while we were going ahead and following these race-based guidelines, that the hypertension control was worse in Black patients than in non-Black patients. So these guidelines are not helping. And also we're 20 years into this guideline, and we have not controlled blood pressure by using these guidelines, particularly in Black patients. Those of us who are working in these systems and working with these patients know that no one drug is going to take care of hypertension, and it's not just based on drugs, but it's also based on the entire holistic picture, right? And the authors of that paper, as well as in the Kaiser study, demonstrated that in order to take care of hypertension in human beings, like we need an individualized approach, right? What's the dose? What are the side effects that human being is experiencing? Do they need another drug? Do they need a second or a third drug? What's their medication management ability? Are there lifestyle changes that can be added? Are they in a food desert, right? Do they live in a food desert? Are they in a place where there's good transportation, where the whole neighborhood is safe, where they can walk around and exercise, for example? And also, are they able to follow up and see the same physician? There are a lot of clinics where folks are not able to establish a relationship with their patient, and they bop around from one patient to another, from one provider to another. But if you have consistent care and you have more clinical encounters, that actually equates to better control. All right, and so what is the future for Circa? We are looking so forward to our launch in May 2024. We are recruiting participants for our subcommittee on hypertension. We are working closely with NKF. I forgot to mention that when we talked about the algorithm. So the National Kidney Foundation, the New York chapter in particular, they have been amazing partners with us in campaigning around Black kidney health in particular. So last year we launched a campaign for awareness. This was the patient engagement process for engaging Black people in New York City around kidney care and their kidney health. We had March is actually Kidney Month, which I learned last year. And we launched basically like a panel discussion. We had like an expert panel, and patients could call in so we could talk to them and explain about the new equation and what this means for them. We helped them develop a website. So NKF has an amazing website on Black kidney health where they call out structural racism. And we also helped them with a summit that we had in October of last year, where we got community-based organizations, health plans, primary care physicians, nephrologists, everyone together to discuss in work groups to discuss what are we going to do about this? How are we going to make things better when it comes to kidney health, and how can we make kidney health equitable? And so partnering with the National Kidney Foundation has been amazing. We are also trying to evaluate the impact of the coalition actively at the moment through a grant with Robert Wood Johnson. And finally, we have been awarded almost $3 million from the Doris Duke Foundation to continue our work for the next 2 years. So that's really exciting. Yeah, and that's it. That's what I got for you guys. I'm looking forward to getting and answering your questions.
Thanks, very nice. Thank you very much. All right, so I guess I can start the, we have time, and thank you for, keeping the presentation as brief as you could so that we can open it for discussion and have more time for discussion, of course. All right, so since I'm the chair of the task force, I have the privilege of probably asking the first question and making some commentary. So CIRCA has really changed the dynamics of how people understand the race part of the equations that we use in medicine. I think before CIRCA, we probably knew that, yeah, in some equations you have the race in it, but we really didn't understand the effect of the race in those equations and how they impact health equity. So we participated in the first round of CIRCA. We are still part of it at Downstate. We are actually moving to the next phase, which is the engagement phase of CIRCA. So I'm very happy to be part of it. The question I have for you has to do with during the implementation phase, we knew that for instance, the EGFR, the effect of the race in the equation was about 4 percentage points in the EGFR. So for instance, if you added the race to the equation using the CKD epi and you got, let's say, 30, if you actually use the CKD epi refit, which is the new equation, you got 30 minus 4, which is about, it's like 3.7. So you go like, 26 point something. So you move from CKD 3 to CKD 4, right? But it happened so fast that it was very difficult to go back and reconstruct those who were actually affected from the beginning and be able to interview them and then ask them, how do you feel, about the change, and ask them from their perspective how they felt the change actually helped them. I wish we could have gone back and reconstruct and get the perspective of those patients who were immediately impacted. For instance, at Downstate, we removed the equation, the race part of the equation in February of 2021, right? And then it was not until later in the year we started all, the momentum on CIRCA began to build. And by the time it was, September, October, we thought we should do this, all the patients had moved to a different class of EGFR. So it's a missed opportunity, but I'm wondering how, from your perspective, you have been thinking much more of this than all of us. Do we have a mechanism to go back and reconstruct the data to figure out what are the perceptions of patients? I mean, we know what the benefit is, but what are the perceptions of patients on the whole change in EGFR, knowing that patients will move from a less form of the EGFR to a more severe form of the EGFR?
Yeah, that's a great question. And that has been like the crux of the work that we've been doing with the National Kidney Foundation. Why we launched that whole campaign last year is to try to get an understanding. First of all, to try to get an understanding, but also doctors don't know how to talk about this. Like, we just don't know how to engage folks, about something that may have been harmful to them. So now 1 minute they're don't have kidney disease, and the next thing they know, they have like stage 2, kidney disease, and they don't. What are you talking about? Last year I didn't have kidney disease, right? Or like you said, somebody had stage 3, now they're stage 4, and they're looking down the barrel of dialysis in their future, right? And so or somebody was stage 4 and hanging in there, and now they're stage 5 and now they need a transplant. This is stuff that's difficult to talk about. I think that we're still trying to, I think the awareness piece is important, and we haven't completely made everyone aware that this is actually happening. I think that we need to, I think everybody's struggling with the idea of how hard it is to kind of like, what were you before the implementation, and now what are you now after the de-implementation? I think that part is difficult, but the important thing is to know that this algorithm has changed, and that may have an impact on somebody's kidney health, and to know how to speak about it to patients who may have questions as to, what do you mean? I thought we were doing everything we could to keep my kidneys healthy. Why is it all of a sudden that am I in a different stage than I was last time I spoke to you, right? So it's more of making sure that folks have the right talking points,
right,
for engaging with folks, and acknowledging, like my whole thing is like, you gotta just acknowledge that it was wrong. Like, you can't hide behind it and say, oh well, I'm not the one who made the equation, so la la la. Like, we're all complicit in the work that we're participating in, right? And it's not anybody's fault per se, because this is the system that we grew up in. But if we now know and we continue to participate in it, then we are complicit in it, right? Awareness is the most important thing. And I think that accompanying our patients along the journey of like, hey, you may have been harmed by this, your kidney health may have been changed by this. We're still here with you, and this is what this means, and this is how we can make sure that you are in the best shape as possible, is important. And then also making sure that we are getting the stories that you're talking about. Like, if there is somebody who has a story, that we gather that data and we understand what that data is, so that we can actually make things better when we're engaging patients going forward. But what I would say is that check out NKF's website. They have a lot of information that we've actually helped them develop the content for a lot of the stuff on their website with regard to Black kidney health and how doctors should talk to patients. I think that's online. I did it with Kirk Campbell from Mount Sinai. Mount Sinai. He's a nephrologist from Mount Sinai. It was a great panel. We interacted with patients. We interacted with folks from the community, and answered questions and gave examples of how physicians should engage their patients around this issue. I hope that answers your question.
Yes, it's very nicely. So we are open now to questions. If you have a question, you can raise your hand by using the application, or you can just type your question in the chat box, and I can read it out. So while we're waiting for that, I can ask another question, which is that circle was mostly, the actual impact was centered around the New York City area, although we want the national impact. So most of the hospitals in New York City now have removed, the hospital labs have removed the race part of the EGFR equation. I'm wondering whether that is the same thing in upstate New York and other areas in the state. That's number one. And then number two, we have Quest, labs, we have LabCorp and all the other commercial labs. Could you also comment on whether they have removed the race part of the EGFR equation in reporting their labs?
Yeah. So the first part of your question, our coalition is focused on New York City, and we are not aware of any other efforts, like coalition level efforts, to de-implement the way that we have engaged in this work. We have been, there have been other, upstate New York has not reached out to us, but we have had other like health plans have reached out to us from different parts of the country. We've had some nonprofits reach out from California. We have another organization we had 2 organizations reach out from California, for example. We had a couple of health plans from different states reach out and ask us about this work and how to develop a coalition and the whole process. And so we do get a lot of questions about folks doing this, but in terms of like, I think this is the first effort in a coalition mechanism to try to kind of move this work forward. So that's, I don't know about upstate New York in particular, but we are very open about the work that we're doing. You know, we're doing these talks, trying to shop them around to whoever wants to listen. And hopefully other folks are inspired to create their own coalition to end racism and clinical algorithms. And there are many to choose from. There's an article called Hidden in Plain Sight from the New England Journal of Medicine, where a lot of this work is based on. And there is, I think there are like 20 something algorithms that they talk about in that particular paper. So definitely check out Hidden in Plain Sight as a resource for other algorithms. And then, I forgot your second question.
Second question was LabCorp and
LabCorp, yes.
Quest
So
Labs.
there are, from what I see in New York, what I see, and I always pay attention, the Quest Labs and LabCorp have de-implemented race adjustment.
Nice.
There are other labs, though, smaller labs that may not have. And so it's important for folks to just pay attention to that. Like, which, you know, are you seeing the double, like, you know, non-African American, African American, like EGFR, those two? Like those, I saw those a lot, and now I don't see them I don't see them in New York anymore, myself personally. But that doesn't mean that there aren't some smaller labs that maybe a smaller clinic or other hospital system could be using. I know if the ones that we're using, nobody else is using it.
Okay, I have a hand up from Dr. Pomerantz.
Yep.
Please go ahead.
Thank you so much. This is really inspiring. I just put the link for Hidden in Plain Sight in the chat. And actually that was going to be my question, is what's the, you know, when I think about these algorithms, PFTs and GFR are the ones that come right to the top of my mind. What do you think should be the next one that should really go after?
Yeah, well, we are going after race-based prescribing and hypertension. That's what we're focusing on. And I know the rumblings are on AI. I think that's the next one that I know Dr. Morse is very interested in AI and the bias that is built into artificial intelligent algorithms, you know. And so I think that's probably after race-based hypertension. I think AI is going to be next on the docket.
Okay. I think that's going to be
interesting.
Easy stuff we do here.
Yeah. Pick something simple.
Something, you know, just a little taste, little.
You know. By 2025, check.
Yeah. Exactly.
Well, thank you for all of this work, and thank you for the presentation tonight.
Absolutely. Thank you for listening.
The topic on hypertension is very interesting. The prescribing hypertension is very interesting. So, you know, this literature that you cited from All Heart, and actually Sunny Downside was part of All Heart. So I remember that one of our faculty members did a great job in All Heart. It was published in 2000, I believe. So all these studies had so many patients. They had like 10,000 patients who were powered to show certain effects. And then they came up with these conclusions, which was, you know, a little bit confusing. But it turns out that, you know, it's now 20 years later, and, you know, hypertension control is still a problem in African-American patients or Black patients in general.
Yep.
So where do we go from here? So should we say that, do we have recommendations? I think that's the question. Do we have recommendations to say, do something beyond what we know already?
Yeah, I mean, I think, well, first of all, if there is going to be a JNC9, we don't want to see race in there at all. Like, you know, like and if they do it, now the thing that's important is that we're talking about race consciousness. That's okay. But race adjustment based on a biological or race essentialism type of philosophy is not what we're trying to promote. And so I think the most important thing is that we need to think through you know, if you're using race, are you using it to tackle inequity, or are you actually exacerbating inequity? So I think that's a really important distinction to make. I think that it is, you know, in terms of race-based prescribing, that's what we're going to figure out. So stay tuned in this next phase of the coalition as we're recruiting folks into the subcommittee about like how do we tackle this issue? How do we influence the next set of guidelines to make sure that, like, yes, there is poor cardiovascular health in Black people, but it has nothing to do with their race. It has nothing to do with the percentage of melanin in your skin. Like, that is not what's going to affect the way a medication is metabolized. Do you know, like, that's not it. It is literally like, what is going on? You do have other comorbidities, and in these folks, they didn't have comorbidities, but maybe they had hidden comorbidities. Or what is the level of stress? What is their ability to take the medication? What is their living condition? Are they like in a housing development in these studies that you know, that is toxic to their health? Like, we all know these things who are interested in understanding the holistic picture of medicine. It's not just your particular health in a vacuum. Like, it's everything that you're interacting with. You know, it's the rage that you have when you're driving into work. It's the rage that you have because someone's following you in a mall. And you're just trying to buy something, right? It's the anxiety of being stopped by the police. You know, like, there's a lot of things that go into the health of a human being that are experienced because of your race, but it's not, you're not metabolizing differently because of your race. Like, that's the incorrect way to think about it.
So do you have a recommendation for, you know, us all? Because, you know, this hypertension, prescribing hypertension is very pervasive, because the teaching is the diuretic to do a better job of salt excretion and that kind of stuff. And so what do we do? Should we start prescribing something else?
I mean, I think we don't have to, that particular guideline, we should probably just stop, right? Like, and anybody who's like taking care of patients with uncontrolled hypertension, like, you know, you're not stopping at chlorothalidone. Like, that's not, you're going to add like, eventually you're going to you're adding another medication.
Yes.
This all hat study was specifically first line medication for Black patients. It's the first option for the Black patients. And what was wrong in that is that, like, that's not helping control blood pressure, right? Like, that's not the thing that's actually control. So I'm not saying that, and I want to be clear, I'm not saying that because race-based prescribing is being enacted, that's the reason for poor control. I'm saying that's not helping. I hope that's clear. Like, yeah. And we shouldn't be like, oh, you're a Black patient, you get this medication, and you're a non-Black patient and you get this medication. Like, what is that based on? Like, that's, and we are going to, and that's why I put the genetic slide up there, because like, somebody's going to say, well, what about genetics and precision medicine and la, 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 la. And it's like, okay, yeah. Okay. Well, we're talking about race, and race as a proxy for genetics is incorrect, because we haven't been doing those studies well either.
Right. Nicely said.
Don't get me preaching over here, Dr. Eyssallenne.
No, it's good. We're trying to get to the details of this. Very nice. Yeah. I'm looking at the chat box. I don't see any questions. I think
somebody here, Serena.
Oh, okay.
Yeah. Do you mind? Can I ask a question? Thank you so much. That it was so great. It was so illuminating and disturbing that we are making major national guidelines based on some silly interpretation of Sweden versus the US.
Can you imagine?
Like somebody trying to put that forth as an argument. But can you dispel probably maybe another prejudice that I trained a long time ago, that the risk of angioedema is higher in Black patients. And I've gotten patients coming back from the ER saying, the ER doctor said, you committed malpractice for putting me on this medicine. And I'm like, okay, yeah, thank you.
You did not commit malpractice. I will tell you that. What I'm saying is, what I would say to that, because that has come up. That has come up about angioedema. But the problem is saying that, like, how are you going to decide based on race who gets angioedema and who doesn't? Like, based on race. So now you get a Black person who comes in, and because you're Black and you're at risk, I'm Black. Am I at risk for angioedema? You know what I mean? And so, and angioedema, to that person, there is a genetic component, and it runs in families. So was there a history of angioedema in that person? And like, so if somebody has a history of angioedema and that has actually been located genetically, then there should be, and if you're concerned, then the teaching we should provide to our students and to our residents and to everybody is, and how we should practice is like, I'm worried about angioedema. Let me get a good family history on making sure that there is no angioedema in the family, and then
in every race.
Then I can justify it, because the thing is that when you're doing things based on race, what do you say? Like, how Black do you have to be? Do you know, like, what about if you're half Black and half white? You know, what do you do with that person? Do you know what I'm saying? Like, are they going to half get angioedema? Like, it doesn't make sense. Like, I'm making, you know, I'm being myself. You guys are making me feel comfortable, so I'm being myself. But I think that, like, I think it's really important to, when those people say stuff like that, if you are grounded, and that's how we started this presentation, if you are grounded in the fact that you know that race is a social construct, that is your rebuttal every single time. It is a social construct. We are not talking about race essentialism. If you're talking about genetics, show me the genetic profile of that person in front of me that I gave this medicine to. Like, we are not doing, this is just somebody who's trying to justify race essentialism. And that's not the right way to think about it.
Right, but thank you. That was very gentle to just remind me. I did pay attention at the beginning, but I see, but it's like it's ingrained. Like all of my training is like, you have to memorize all these associations and to undo that, but I'm going to do it, and thank you very much.
No, absolutely. Listen, me too. I was trained in the same system. I was a resident during Biden, when Biden came out, and they were like, oh my God, this is what you have to treat Black people with heart. And I was a resident, so I was like, okay, we need to treat Black people with, you know, I was doing the same thing until like you start to process and you learn more and you try to understand that we've been just doing it the wrong way. And there's no criticism to anybody who has been practicing this way, who's on the call. Like, this is why we're doing this. Nobody wants to, number one, feel like they've harmed anybody, because that's not why we became doctors. We didn't come here to harm, but we don't understand that we were trained in a system that was structured against Black people because of the history of this nation. Like, that's just what it is. And now that you know, you can't do it anymore. That's it. Like, don't do it anymore. Like, that's it. And lean on the folks who understand this, right? Like, this is a journey, and we should hold hands and go through it together, right? Like, we're going through a journey, and it's a retraining of the brain. Like, how often do we see a Black sickle cell patient and we're like, yeah, black is a sickle cell disease, and it's not a sickle cell is a Black disease, and it's not. There are Latin folks that have sickle cell. I saw the same thing with cystic fibrosis. I took care of a Black woman with cystic fibrosis, but they don't teach you that. It's like, white people get cystic fibrosis, Black people get sickle. Like, we can't stop. We have to stop that. Like, we have to literally be okay when somebody tells you about race. Thank you for sharing. That's amazing. How does this fit in the fact that race is a social construct? Like, let's have that conversation. And that race is not biological. Like, that's where you start. That should just be your starting point. And, you know, you're going to have to read it again, and you're going to have to read it again, and you're going to have to read it again. Like, you have to retrain yourself, because the entire curriculum, I did medical education for a long time. The entire curriculum is based and steeped in race essentialism. It just is. And we're just now starting to crack the surface. So continue to read, continue to come to these talks, continue to be asking the questions that you are. Like, that's how you change it, you know, little by little, baby steps.
Okay, very nice. I saw something in the chat box from Meryl Brown. You want to make your comment? It's really not a question, it's a comment.
Good evening. Yes, I was inspired about, you know, ophthalmology. I noticed that there's in Asian patients, the dilation of the pupil for the eye exam can tend to be overdosed, because at first the dose that we give does not affect. So they give another dose and we end up giving too much to these patients. So I've seen instances of these. So I think I'm curious to explore this and see if maybe there's something that we can look into to maybe space out the timing of these doses, or just look into, I don't know why that might be happening, but something on a molecular level might be happening there. That's my curiosity.
Yeah, I mean, I'm not familiar with that particular algorithm or guideline when it comes to ophtho, but if anything is I think what I've achieved here is that now folks are going to ask questions when they see things that are stratified by race. Like, and if there's something attributed to race, you're going to ask yourself a question, and that is major. That is major. So I think that's wonderful. Please do keep us posted.
Thank you so much for this talk. And if anybody wants to collaborate with me on this investigation, I would be honored.
Yeah.
Very nice. Well, you should join the DEI task force. Isaiah, we have the recruits, and we can begin to talk about research in the DEI, and we can share ideas and connect you with other investigators who are interested in the subject.
Thank you so much.
I think we are getting close to the end. We have 7 more minutes. If there are no additional questions, I would like to first thank the DEI task force members, the leadership of the NYACP, and all our membership, and those who have made time to join this meeting this evening. And more importantly, our speaker, who has really taken us through, the very essence of what she described today as so important to taking care of patients and making sure that we have health equity while we're taking care of these patients. So the what she described today, mainly on the 3 areas, right? The EGFR, the VBAC, and then the pulmonary function test. I'm sure the prescribing in hypertension will become a big deal very soon, and we would like to participate in that as well at Downstate. I'll talk to you offline about that. And all of you who have the chance to participate in any of these equations, it's actually very, very beneficial. When we went through the whole exercise of deploying Circle, it was so interesting. We engaged so many people that we didn't even think about when you are trying to do something. We engaged the pathology and the lab services and the legal and all the other people all in one room trying to figure out what is the best thing to do for patients. So if all of you take this topic back, you read the VIAS paper that was posted in the chat box, you see more of the equations. I think there are, what you said, 20 equations in that publication. Whatever you can do in that regard to reduce the use of race in these equations would go a long way to reducing health equity. So without further ado, thank you, Dr. Eyssallenne, and we would hope that you come back next time to explore more of these kinds of topics. And again, thanks to all of you. And now we adjourn, we close. Thank you.